think so, yes.
All right. Just before we start, I'd like to acknowledge that I am meeting on the lands, the traditional owners of these lands, the Wurundjeri people of the Kulin Nation, and we respect their elders past, present and emerging, and welcome any Aboriginal or Torres Strait Islander people here today. Thank you. And I'll introduce Elizabeth.
Yes, hello, thank you. Thanks for coming along today, everybody. Today, our speaker is Associate Professor Samantha Loi from the University of Melbourne. So Samantha will report back to us on the results of a survey that you and your clients might have participated in. And this is all around seeking support for behaviour change for people living with younger onset dementia. So I'll throw to Samantha to present her findings. Thank you.
Thank you. And I want to just say thanks again to Sarah and Elizabeth for coordinating and running these meetings. So important for all of us who work with people with young onset dementia. And also do want to thank the people who were interested and involved in this study, because it's a really important topic for people with young onset dementia. So I'll just, hopefully this won't take very long, but we'll hopefully generate some questions about what the findings are showing. And I think it was a study which was an online study, so I'll share some of the findings and the background behind it. So as we all know, behaviour change is really common in young onset dementia. People are living with young onset dementia for, at least a decade, 12, 15 years, often at home. And often the family carers are having to manage these behaviours of concern or behaviour change. And these can be agitation and aggression and depression, etc., and can be really hard to manage. And the really important thing for young onset dementia is that these behaviour changes can have significant impact on both their caregivers and the person living with young onset dementia, so adversely affecting quality of life, morbidity and increased mortality. And there's even some evidence to show that the behaviour changes in young onset dementia might impact caregivers more so than that of people who have older onset dementia. And there's been a number of studies about that particular scenario. We looked at behaviour change in young onset and older onset dementia previously. We looked at some of the referrals from the Dementia Support Australia, or DSA. So as we know, DSA do a lot of non-pharmacological management for behaviour change for dementia, and they also receive lots and lots of calls for people with young onset dementia. And so what we did previously was we looked at their database from the past 2 years, and we wanted to see if there were any differences in the actual behaviour changes seen in YOD compared to older onset dementia. We wanted to look at some of the demographics. And as you can imagine, for the YOD group, so less than 65 years old, in terms of the dementia type, there was almost 8 times as many people with FTD compared to the older onset dementia. And because people with young onset dementia are more likely to be living at home, there were about 3 times as much people who were living with YOD in the community. So being referred from being at home compared to older onset dementia, where they were much more likely to be living in residential care. So you can see that the behaviour change is really, the strategies we need to think about are really impacting on their caregivers at home and how we can, empower these caregivers to help manage these. In terms of how we looked at these behaviours, we looked at the MPI. So the MPI looks at various domains and different types of symptoms. And interestingly enough, with this study, in terms of the NPI and how severe and distressed the caregivers were affected by the behaviour change, it was very similar amongst the young onset and older onset dementia. So both people, the sort of caregivers, so these are both formal caregivers from the residential care facility and the informal caregivers, they nominated about 5 symptoms, about 5 domains, and they nominated the severity very similarly about 10, and they nominated that they were quite distressed about 14, but both very similar with young and older onset. But I just thought that would be a bit of interesting background leading up to the study, which I'm going to talk about today. So it's all well and good saying there's behaviour changes and there's different types of behaviour changes, but one of the things I'm really interested in as a clinician, but also as a researcher, is how do people look for services to support them in finding strategies for these behaviour changes? So when I worked with older people and who had older onset dementia, often we would say, hey, go to your geriatrician, go to your aged care services, go to aged person's mental health or your GP. But for people with YOD, it can be really hard because often they fall through the cracks of the aged care services and also adult services. So you try and refer someone with YOD, with these behaviours, to aged services. They say, oh no, they're too young. But then where do you go when they're younger? So you can go to your GP, you know, who do they go to? So I was really interested in finding out who exactly are caregivers and people with young onset dementia, who are they going to try and seek this help? What kind of help are they looking for? So who do they contact? Is it GPs? Is it mental health services? Are they private specialists? Are they emergency services? And I also wanted to find out what was the experience in seeking support for these services. So were they satisfactory? How long did it take? Did they give them the support they wanted? And then the last thing I wanted to find out was what kind of support did they receive? So we all know that managing behaviour change, you really want to emphasise non-pharmacological strategies rather than pharmacological strategies because there's lots and lots of side effects. However, I wanted to know what exactly was being what recommendations were being given to these people who were looking for support. So that's the sort of premise of the survey which we looked at. So what we did was we designed a survey. I can put a copy of the survey at the back of this presentation, but we really wanted to, I guess, look at these sort of topics and try and find out the answers for them. And the really important thing was with this survey, we talked to a number of people who had young onset dementia and carers and healthcare providers to get their opinions about whether the survey was appropriate, had the appropriate wording, was it too long, was it too short, etc. So we really wanted to make sure that people with lived experience were involved in the design of the survey. And the survey we rolled out late last year for a couple of months this year, so from December to April of this year. And we really were looking for all stakeholders. So the survey was targeted for people with young onset dementia, their family caregivers, so their informal carers. We also wanted to look at formal caregivers. So this included healthcare professionals like clinicians, people who lived in residential care and were providing care from that capacity, and other healthcare service providers. So we really wanted to have a wide reach. I'm not sure how good we were at trying to get all these people, but we did try our best. So we did go to Sarah and Elizabeth. We went to our own networks. We went to sort of various other sort of services, social media, etc., to try and get that reach. And in terms of the other information we were getting, apart from the actual services and the support they received and how satisfactory they were, we wanted to look at some of the demographics. So what were the kinds of people, what were the kinds of dementia who were going to be, completing this survey? We used the NPIQ. So this is very similar to the NPI, looking at the different types of symptoms like agitation, aggression, etc., the severity of these symptoms and the distress. And then we looked at had they sought support for these behaviour changes and what were the experiences. So I'll just show you some of the results of the survey. So it was over a 4-month period. We used the online survey platform called RedCap. So you can just click on the link and then fill out the survey. The survey itself took about probably maybe 10 minutes to complete, depending on how long and how much detail you wanted to add. And we also got this ethically approved by the university. And in terms of the survey results, it wasn't a massive sample, but I still think it wasn't bad. We got 36 people who completed the survey. And we did get, a relatively, good range of people completing it. So there were 4 people who had dementia. There were 17 care partners or family members, so providing that informal care. And we did get 15 formal caregivers. So these included people who are medical, a couple of nurses, and a couple of allied health who completed the survey. And this pie graph here shows where the participants came from, so which state, and predominantly from Victoria. So 75% of respondents came from Victoria, a little bit from South Australia, and then New South Wales and Queensland. So not many. So really a bit of a bias towards Victoria, which is probably, from me and the network here. But I think that's not bad. Okay, so I can tell you a bit about the participants. So I said there were about 4 people with young onset dementia who responded. On average, they were 58 years old. There were more females who responded, and they were all living at home. And in terms of the YOD types that they nominated, they had Alzheimer's disease, a language variant, frontal temporal dementia, and DLB. And then in terms of the formal caregivers, so there were 17 of them. On average, they were 46 years old. There were 6 females to 8 males, and one of them preferred not to say what their gender was. And they were, mostly medical, so 9 medical, 2 allied health, and 4 nursing. And then there were about 15 care partners who were also on average 59 years old, mostly more males actually who responded. So 11 of them said that the person they were caring for lived with them at home. 4 of them were in residential care, and 1 of them was in a supported living accommodation. And in terms of the YOD type, was mostly Alzheimer's disease and FTD. So the care partners were asked to complete the NPIQ, and they nominated about 4 symptoms which were problematic, and the severity was about 10 and 11. If you think back to the other study, it was almost on par to what the other study found in their NPI. So this is about some interesting information about the actual behaviour changes and some of the support that they receive. So this chart's quite complicated. I know I've put here 35, so I forgot to add one other person, but the most common types of behaviour change nominated by all these people were appetite and eating changes. So about 63% of and obviously you could pick not just one particular behaviour change, you could pick a number, and I think I said 4 were on average. So appetite and eating changes was one of the more common types of behaviour changes nominated looking for support. Agitation and aggression, 60%, and apathy, 60%, which is not surprising. That's some of the stuff which I hear about in my clinical practice about the apathy and agitation and aggression. Though I was a little bit surprised about the appetite and eating changes. And then you can see here that 28 of the people, so nearly all of them, had sought support for these behaviour changes. And then these are the services which were approached. So the general practitioner, 43%, emergency department, 8.7%, ambulance, etc. But the most common services approached was the GP, so 43.5%, Dementia Australia. So almost half of people said they looked towards Dementia Australia for some help. And then Dementia Services Australia. So they were also one of the more common services approached for support. And then I've put here adult mental health services, 22, so only a few people, 5, and aged mental health services, 2, 8.7%. So these are the 3 main services are really GPs, Dementia Australia, and Dementia Support Australia. If I look at this figure a little bit more closely, we can see about what happened in trying to get this support. So, for example, 5 of them said they were actually unable to get any support for these behaviour changes, and 3 of them said they're still waiting. And in terms of how long it took to get the support, the most common time period was between 3 to 6 months. So about 18% of them said 3 months, and 21% said about 6 months. So it is taking a bit of time to get that support. And when we asked them about what kind of support did you receive, so 20 of them responded to this particular question. Some of them got home visits. So 6 of them got home visits. And then some of them got a telehealth appointment. So 4 of them, some of them got an in-person appointment. There were lots of phone calls. So 50% received phone calls. Interestingly enough, 3 people had hospital admissions. So I'm not really sure what that was about. That sounds pretty severe. And then other. And this little figure here shows the type of support received. So really only categorised into the medication, non-pharmacological strategies, and both. And you can see here that 9 people, or 42%, received both. 7%, received only medication, and 5 people said they received non-pharmacological strategies. So that's quite an interesting result, I think. If I move on to the next part of the survey, we were interested to see whether, depending on who responded to the survey, did they nominate different behaviour changes? So, for example, with the person with dementia, did they have something different compared to, say, the informal caregivers and the formal caregivers? So this is what this first graph shows. So the blue refers to the person with dementia. So I would look at the highest sort of figure. And so the highest figure for the blue is this appetite and eating changes. So it looks like many of these people with dementia, they were the ones saying that they had appetite and eating changes. And you can see here also that the informal caregivers, this appetite and eating changes was also very high. So about sort of 70% of informal caregivers were saying, look, I need help for my loved one who's having appetite and eating changes. So that was pretty high. Also, the informal caregivers, you can see here that agitation and aggression was about 60%. So the informal caregivers at home, they were the ones often saying, look, agitation and aggression was something they needed help for. And again, here, the apathy and indifference was about sort of maybe 50%. And then you've got a bit of disinhibition here, irritability, lability. These are probably also sort of, the 40%, 50% mark. That's quite interesting. And if you look at the formal caregivers, so these are the healthcare providers. These are like clinicians or nursing staff or allied health, for example. In terms of the behaviours they're saying they wanted support for in the grey, interestingly enough, agitation and aggression, that's probably the highest nomination for the behaviour change. About 80% were for agitation and aggression. And then apathy and indifference was also very high. So I sort of found it quite interesting that depending on who you were, there was, what you wanted help for was quite different. And we know that in reality that, for example, if you're in a facility and someone's got a bit of apathy compared to agitation and aggression, whilst apathy is important, if someone is agitated and aggressive, you're more likely to seek help for that a bit quicker, for example, than the apathy. But I found it really interesting that that apathy was actually something really interesting, was actually just almost as high as the agitation and aggression from the formal caregiver perspective. Whether that was because when they were talking to a family member and the family member said this and they made the referral, it's unclear. We can't really glean that from the survey, unfortunately. But that's quite interesting. And then we also were interested whether, depending on the person who responded, whether they approached different services asking for support for these behaviour changes. So again, a few things I can highlight from this graph. So again, the blue is from the person with dementia. They were much more likely to want to go to the GP. They were the ones who said, I'm going to go to my GP. And they also were likely to go to Dementia Australia. Similarly, with the informal caregivers, going to the general practitioner and Dementia Australia was pretty high. However, if you were a formal caregiver, and again, the numbers are pretty small, only 8 here, you are more likely to go to Dementia Services Australia. So maybe you knew more about Dementia Services Australia than the other sort of, the informal caregivers. And also in terms of going to mental health services, going to an adult mental health service or going to an aged mental health service was higher if you were a formal caregiver. And again, that might be to do with knowledge about what services are available and being able to access them as opposed to a person with dementia themselves who then might go to a GP and then maybe the GP then does the next referral. So that's that graph. And this graph just looks at the recommendations. So we were also interested whether, depending on who was the respondent of the survey, what kind of recommendations they were given. So was it, just medication? Was it behaviour strategy, etc.? And it says, this graph shows that if you were a formal caregiver, you were given both. You were given both medications as a strategy as well as non-pharmacological strategies. But if you were the person with dementia, you got non-pharm, which is really good as well. If you were a formal caregiver, it was kind of split across all 3 categories. You got some medications and a bit of this and that. So that's about sort of the behaviour changes and the supports. The next slide here looks at the general satisfaction with the services with the support they receive. So we had a couple of sort of Likert scales where you could say, I did not know where to start looking. Was it difficult to access the service? The process of accessing the service took too long, and it would be useful to have some guidelines. So you could respond completely disagree, neutral, agree, and completely agree. And so the bar, the sort of colour, which is the biggest, is what's the most common response. So you can see here that, what stands out here is that if it would be useful to have some guidelines. So about, sort of more than 50% of people said, look, we would like some guidelines in how we could seek support for behaviour change. That was completely agree. And then about sort of maybe 40% of people said, look, it took too long. And similarly, 40%, it was difficult to access a service to manage these behaviours. And then probably about, if you're looking at agree and completely agree, probably about, 50 to 60% of people were saying, look, I didn't know where to start. So it was hard. It was really hard to get that service. And this slide just then breaks down the satisfaction according to if you were a person with dementia and a family member, for example, in the first picture here, and then if you were a formal caregiver, what was your satisfaction? So just for my interpretation, what I can see from here is just this last little statement saying it would be useful to have guidelines. You know, the people with dementia and the informal caregivers, the family members, they're really saying, hey, we really would like some guidelines. So, good sort of 60% of people are saying we completely agree. And for the formal caregivers, they're saying, look, you know what? We agree, but in terms of completely agree, it's about 30%. So I guess that's saying that there's a bit more knowledge, which probably makes sense. But here we're really wanting to, I guess, empower people, the family members, at where to go to get support for services. And you can see here also, I didn't know where to start. A lot more people here, from the family member perspective, they didn't know where to go. 40% here, 50%, it was difficult to access the service. And again, here, completely agree. About 50% of people are saying it took too long. For their formal caregivers, maybe they have less buy-in. They're not sitting at home with the person with dementia. So for them, the sort of completely agree, the proportions are smaller. So I didn't know where to start. It was about 10%, 20% difficult to access a service. In terms of taking too long, about 30%. And similarly, it would be useful to have guidelines, about 30% here. And that's completely agree. Okay. So that's probably the main findings from this. It's a small study and it's an online study. I know there's many limitations and biases in this particular study, in particular that it was very, very Victorian-centric, and not many people with dementia complete the survey. But, we did find that behaviour change is really common. And I did find it really interesting that appetite and eating changes were really common, a really sort of, common reason why people wanted to help. So that's something which I didn't necessarily think about in my practice. And maybe I need to be asking people about, hey, is your person, is your loved one, are you eating? Are they losing weight or are they putting on too much weight? What's happening there? Are they eating too quickly? And we know that in certain YODs, like FTD, for example, the eating can be sort of, quite problematic, like sweet foods and eating very quickly. The other main finding is that, look, support is really needed. People are looking for support and they're having trouble finding support. Wait times are between 3 to 6 months, which is I think it's quite long. I think it's really hard to try and manage things like aggression, agitation, apathy for 6 months on your own. In terms of, what kind of strategies were being recommended, 2/3 were behavioural strategies. That's not bad. I think I'm really pleased that people are getting non-pharmacological strategies. It can take a lot more time, but, it's more effective and less, I guess, not causing side effects and causing people to fall over, for example. But, about 1/3 of people were only receiving medications. So whether this is because, it's very severe, is it because, people weren't able to go into the home and give them interventions from a non-pharmacological strategy? I'm not really sure. And the other main finding is that, people, particularly the informal caregivers and the people with dementia, there's a lot of trouble finding support. And they really would like some guidelines in how to manage this. And so that's probably the main sort of findings and take-home message from this paper. And I'm pleased to say we managed to get it accepted to a little journal, so I can share that URL with you as well. But that's, I think, sort of quite interesting, and I hope that maybe we can have a bit of a discussion about that. So I might just stop sharing and see if there's any questions. Is that okay, Sarah and Elizabeth?
Thank you.
Yeah, thank you very much, Samantha.
Any sort of thoughts? Is this something which you guys are seeing, or, I mean, they're not all surprising findings. The main thing I was surprised about was the appetite and eating, and did make me think, okay, I really need to ask people about that. But I know that people have a lot of trouble. When I say, hey, go and call these people, I probably should be helping out a lot more. So, for example, what I do now, I actually make the referral to DSA. So I actually go to DSA because I think they're really good for the non-farm.
Yeah.
So I make the referral myself, so then the caregiver doesn't have to do it. So I do it right in front of them, do that. So I try and take that first step now. And I know people are reluctant to go to mental health services. There is a bit of a stigma alongside with that. But I do think, aged mental health services are probably a little bit better geared to look at behaviour change associated with dementia rather than your adult services. But often they are reluctant because, they think, oh, they're too young.
Yeah, yeah.
Yeah, but they're not bad. I think they're pretty good. Probably a little bit more experienced than adult services, for example.
Yeah. Samantha, I was really surprised at the numbers you got, considering kind of, your clout and networks for sending things out.
Oh,
Do you think it didn't reach enough people, or do
I
you
have no
think?
idea, to be honest. If you have any strategies or any other tips, I was a bit sad. I thought 36, surely
Yeah,
we'd like to get 50, and I don't know whether people are quite tired of filling surveys. I know you sent it around, and obviously I sent it around as much as I could, and that's probably why we got a lot of medical people. So 9 is still, they're probably all from my service, which is a bit of a bias.
And a lot of Victorians.
A lot of Victorians, and because I sent it to Monica, who you also know,
Yes,
so that's probably
yes.
why there's a bit of a South Australian sort of focus. But yeah, I was a bit sad. I was like, I was really hoping for a bit more, because 36 is pretty pathetic, really, and I really wanted to get more people with dementia completing it. If I could get at least 15, 15, 15, I'd be a lot happier.
Yeah,
But
yeah.
I guess I tried to get people to review the survey and think whether it was too long or too short. You do have to have that balance, isn't it? You can't make it too short because you won't get enough information. But if it's too long, people are going to get tired and think, you know what, I'm just going to stop.
Yeah. And I think this is an issue that we're all coming up against is contacting these people. If they haven't made contact with services,
Yeah.
where are they and how do we get to them?
I know. How can we help them?
Yeah.
What can we do? Because we know they're out there.
Yeah. Yeah.
Yeah. So, I mean, I think it's still, interesting. There hasn't been a lot actually written about people. We all know about there's behavior changes and we know that they all need help. But as far as I know, there hasn't been a lot written about the actual experience. And I wanted to just capture, because we know that people have trouble. I really wanted to capture that they're having trouble.
Yeah.
That's probably why I'm still happy that, we got some feedback and that
Yes.
they are having trouble. So now I can say, hey, people with money, we need some help with how can we, how do we, do we need to get GPs, or, what can I do? What can we do?
Yeah.
Is there something we can put on the websites or whatnot? Who do we say people go to? People are going to DA, people are going to DSA. That's good. People are going to GPs. What can we tell GPs? For example.
Yeah. Yep.
Any other sort of thoughts or comments?
Samantha, I was interested, and it's great to get the referral to DSA or DA, which do a great job, but then sort of like the next level down of service delivery, so the service providers and things like the COPE program or the TAP program, which is being trialled at the moment, like that's where I find, having worked in that area as an OT, contacting GP offices or practices, and they will say, oh, that's a great program, but then generating that next step. And I think the way with the retreats like you're doing, Sarah, and the promotion that Tamar and people like that are getting about the retreats is fantastic, but there's other programs as well, and how we get some bit more marketing around that, or just the message across, because DSA and DA don't go out to the house and sit in the home with the families, and I think that's where you're going to make a big piece of the puzzle, help with these behaviour changes and supporting the care partners. Yeah, really, so I'm not sure if that with that information, how do we disseminate that sort of information? I know there's websites with, or the just for example, OT Australia have, like, you can search for an OT, or the COPE website, just for that example. But unless you know that, you can't go there. So
that's quite interesting, Naomi. So what I wanted to also share is that the Young Persons in Nursing Home Alliance has received some money from the government to actually look at pathways to care. So what I would also want to do and try and get your help is we want to try and look at some of these things. And, we've tried to get some services, and I think we did something about Victoria, which was also very limited, and things change so quickly. So, people will set things up and then money runs out, and then people set other things up. It's so hard to keep things up to date. But this particular organisation, Young Person Nursing Home Alliance, they are really keen. They've got some funding to try and look at these pathways, all the different services all along the road. So not just the sort of, pre-assessment service and the diagnosis and how should we give the diagnosis, but what happens afterwards. So the stuff which you're talking about, Naomi, and it's all very state specific too. So it's all very different. So this project's going to be huge, and, I will really want, your help in whatever way to try and work out what's going on, because we know each state's different. And so our YOD special interest group is hopefully going to have, state people who can then go and say, hey, what is happening? Who do we ask? We want to find out what the experiences are from the people with dementia, their care partners, and the formal people. And then we want to find out what exactly is available. Because as you said, Naomi, there's so many different things. I'm not aware. I don't know what's going on in WA, but there's some great stuff. I don't know what's going on in Tasmania. There's some really good stuff in Victoria. But what's happening in Queensland? What's happening in the other states? So this project is sort of aiming to really do a mapping process of this, and then come up with a sort of, a bit of a program of a roadmap of care from sort of moving up to the assessment, getting the diagnosis, and all the sort of post-diagnostic support. So that's a pretty big project, but that's something which we're really keen to do, and we're going to run some sort of workshops and stakeholder groups, which hopefully some of you would be really, want to be involved with.
Samantha, that's not duplicating the work that's just been done on the pathways and referral to care for people living with dementia by the PHNs in Victoria?
I'm not... That's very interesting. Let me just... I don't know, actually. I don't know much about that. That's really good that you've said these things.
Elizabeth, correct me if I'm wrong, but that was a project run by the Victorian or the Melbourne PHNs, mapping out a referral pathway for, not necessarily, was it YOD or was it just
No, I think it was all dementia.
All dementia.
Yeah. Okay. Yeah.
So you might find that some of that work has been
done. Is that just the PHNs in general or one particular one? I'm just trying to see if we can find it.
It was 3 of them and not the southern.
Okay, so the eastern and the western.
North and western, yeah.
Okay.
I can probably find a contact for you, Samantha.
That'll be great, because that'll be really good. So obviously we don't want to replicate what's been done before. And obviously Victoria, if they've done some of that stuff, that's really good. And obviously the YOD stuff will be perhaps a bit different. But certainly the other states would be very interesting. And if they've got a particular process which has worked, then we would be keen to that, because we don't want to like reinvent the wheel. So I think we're sort of thinking of creating a bit of an experience survey about sort of various aspects and what people find, because it's obviously not just the sort of, cognition and the functional stuff. There's like driving, employment, sort of care for children, sort of psychological support. There's all the behaviour change, and obviously, is how long is your arm in terms of genetic testing, advanced care, all those things are massive.
And Samantha also, and I am a bit biased about this, but the web app and NANU, My Dementia Companion, has mapped out all of that, including driving, care of children, pensions, all for all states of Australia, and all customizable to state.
My Dementia Companion that's the
is the web app, so it might be worth, instead of again duplicating that work, working out whether or not you can work together with his team to use the app or to map some of the pathways within that app or something.
Okay, that's really good. Thank you.
You're welcome.
That's fantastic, actually. This is all the stuff which, I'm not, I can only be on top of some of the space, not...
Oh, totally understand. And that's been our mission, I think, is to just connect some of these wonderful projects with each other.
Yeah, thank you.
So that we all get the benefit.
Definitely. That's fantastic. I'll be in contact with them. And if, Elizabeth, you've got the sort of, a link for the PHN.
Yeah, sure.
That'll be really helpful. But I think it's so it's obviously if people have done it, then that's good. We can just get to it. and see what's missing. And you know, if my dementia companion's done it all over Australia, then that's great.
Yeah.
Maybe I can go on a holiday. No.
It's just getting people to use it, Samantha.
I know. So I don't know why there's been sort of limited uptake.
Yeah, it's gaining momentum, which is fabulous.
Yes.
With different organisations taking it up. So it's just taken a while for the benefit of it to be seen, I think.
Yep. Yeah. No, that's really good. Yeah, no, because I think we always talk about apps and stuff. It's like, well, there's one there. We should be sending people to use it.
Yeah.
Yeah. I think I was in contact with Nan. I think I responded, but I think they might have been quite busy at the time because obviously
quite possibly.
Yeah. No, that's really interesting. Okay, that's good. Any other sort of thoughts? Because I mean, the project we're going to do is sort of starting next year, but I'm sort of putting a bit of background work. But you know, we would, in terms of looking at what my dementia companion has done, you know, is it YOD specific or is it just dementia specific?
Dementia specific, but as a carer, if you go in and specify an age, it will only give you the YOD options. If you go in and specify that an age over 65, it will just give you all the aged care options. So, but the behaviour stuff and the activity stuff and the ideas and tips are all for all ages.
Okay, that's fantastic. That's really good. Okay, I'll definitely look into that, and I might contact Nan again.
Be worth it, I think.
Yeah. Okay, that's good. I'll put in the link for the paper just for your information.
Yes.
So I know it's only 36 people, so you know you got to start somewhere.
Absolutely.
Yeah.
Were those people, Samantha, all through sort of your diagnostic service process?
Oh, well, we did. Obviously, I did send it to my colleagues, but I sent it to you guys. I put it on the web. I sent it to my other colleagues. I sent it to her colleagues. We had the YOD network as well, attached to the YOD special interest group. So we sent it, you know, we put a list out to them saying, hey, can you send it to other people? That sort of snowballing.
Yeah.
But I guess perhaps I was probably a bit more hassly of people in Victoria, so I could actually, you know, complete it. So I know there's problems with that.
We find that often, that it's just really challenging if it's not a trusted, known referral source into anything, even if it's a really helpful, useful service.
Oh, totally.
If people haven't heard of it before and they're already so stressed and overwhelmed, it just falls down. Which is a shame, because it's a really tricky problem to tackle.
It's hard, and that's why you guys have been really good, because everyone knows who you are as well. But definitely I know that Natalie, I know that people with dementia completed it, and that wasn't because I was asking them, because you can't really do that. But I know there's a couple of people from your network who reached out and said, "Oh, look, I've completed it." I'm like, "Oh, that's amazing."
Right.
So that was really good.
Excellent.
But certainly the network's been really helpful for that. So I really felt like I wanted to feed back some of this information.
Thank you.
To know that they are validated, that the concerns that they've had and the difficulties, you know, it's there. And hopefully people, you know, can stand up and say, okay, well, what can we do about it?
Yeah.
Yes.
As in, you know,
Thank you.
Cool. That's probably all I've got to say about that.
Does anyone have any other questions or comments?
Sam, I was interested to know if in doing the survey or talking to the people when you were developing it, the issue of the key worker that is no longer in existence came up, because
when I talk to a lot of people, everyone talks about they miss the key worker. Yes.
Yeah.
No. When we hear about, you know, the breast cancer nurses, like, you know, that's what we really need. Which obviously we had and worked really well.
We
didn't have that as a question on the survey, but it always comes up, and especially when we speak to people from DA. Like I met with someone a couple of weeks ago, and they brought it up. Everyone talks about the YOD key worker program.
Interestingly, I've done a few palliative care webinars lately, and you know that's been a key sort of thing that they've talked about as well, having a navigator, and I think that would tie in well, like, you know, even from point of diagnosis, it, you know, could do the same thing.
No, I think that person that they can go to who can help them along the journey to make it a bit easier, whether that is a person, and if, you know, the My Dementia Companion is something which, you know, can help as a surrogate, you know, it's not a, you know, it can help lead them in that way, but have access to a person, you know. Yeah.
I was just going to say, Samantha, it's
Hi,
Penelope here. Hi.
Good to see you.
Yeah, you too. Did you approach the CADAMS clinics?
No. Not specifically. I probably sent it to maybe a few of my sort of colleagues in the CADAMS clinics, you know, to complete and pass on. Whether they completed or not, I'm not sure. But you're right. I probably should have had a wider reach. I know CADAMS often say, look, it's above 65, but some CADAMS do, some memory services do see people under 65.
Yeah.
So that's probably, you know, could definitely have reached out there further. But certainly, you know, strategies in how to get broader reach would be really important, because when we get this other sort of project going, we really want to be able to get quite a wide reach and get many people, you know. I would hope we'd get more than 36 responses.
Yeah. I mean, unfortunately, they don't all go to the Royal Melbourne
Of
Clinic.
course. Yeah.
Which would be great if they did.
Well, the CADAMS clinic, they know that if they're under 65, they'll send them to us. Whereas I know Western Footscray Clinic, they actually do see some under 65. So yeah, it's just, you know, everything's obviously very, and
ECDC they do as well.
They do. I think we did send it to them, so we probably got a few people from them, but definitely we did send it to them. We know that they're very strong in that area.
And just on your question too about or your comment really is, you know, so often how is it we all see people who say, oh, I wish I'd known about your service in the beginning. We hear that, don't we, everyone? So often.
Yep.
So who is not telling people where to go?
Well, that's why it's interesting, isn't it? Because, I mean, I'm really pleased that DA and DSA were up there, because that makes me feel that whatever you guys are doing, you're doing the right thing. People are going there. Yeah. Something's going right. So, you know, you've got the reach, which is excellent. So that's definitely one pathway.
I know years ago we estimated, and I don't know if that's true now, that we only saw about 10% of people with all sorts of dementias. So it's interesting to know, isn't it, where people are going, or are they going anywhere at all, apart from maybe their GP? Yeah.
Just out of interest, and sorry, this is a bit of a sidestep question, but Penelope, do you know if that type of statistic sort of evaluation is ever done at DA? Like, do they look at that?
I don't know where that came from. It's just stuck in my mind. And look, it was probably 10 years ago they were saying that. So to be fair, I don't know if that's still the case. I would hope it's a bit better. You know, the educators, like we used to have a program here to educate the medical students. I don't think we do that so much. And you'd like to think that I know with my own GP, and I said to him one day, I said, oh, when you suspect a patient might have dementia, what do you do? And, you know, they didn't even know about the CADAMS clinic.
So this is
when they did find out, they said, oh, such a long waiting list. We tend to send people to private geriatricians, which is fine, but not everyone can afford that. So,
exactly. And I think the biggest thing, as often we know, because we're okay at it at Royal Melbourne, but you know what happens afterwards. So you know, CADAMS clinic, they're really limited in that. We try and say we're doing ongoing care, and we do, but as you can imagine, the more and more people you get on your books, you can't actually provide the care that you want to provide. I mean, I used to see people every 3 months. Now I see them every 6 months, and now I think it might even be every year. So we do rely a lot on the GPs for that in-between stuff. But I think having a navigator or My Dementia Companion to help them, you know, go through that course is probably going to be really helpful as well, because a public service can't do that. Obviously, if you can afford to see someone privately, then that's different. But you know, we know there's so much financial stress when you get dementia. It's really hard to keep seeing a private specialist.
Yeah, and I used to do the YOD key worker role, its position, which was just, I loved it.
Yeah.
But, you know, that was the NDIS took that away.
That's right. And I know you've got a very nice sort of YOD program on your for DA, so that's good.
Yeah.
Yeah. I think I reckon if we ran some of these workshops, there would be a very overwhelming response for sort of the YOD key worker to come back.
We just need more funding, don't we? For
everything.
Yeah. Always, yeah.
Yeah. Any other thoughts?
No, we just need to keep on keeping on.
Yeah.
I think the more we hear from, researchers as well as entrepreneurs, as well as little single organizations, the more we learn from each other.
Yeah.
And it's having benefits. It's showing benefits now, I think, that we're actually able to link some people with other people and just educate ourselves a little better about what's around. I've written down, Elizabeth, we've got a job to find someone in Tasmania, New South Wales, Queensland, Territory and ACT to come onto this network.
Yeah, that'd be good.
Yep. Yep.
Start lobbying.
We might have to share a couple of people, get them onto our YOD SIG. We're going to steal Naomi. WA. Yeah. All right, I might shoot off, but I really thank you.
Thank you very much.
Thank you, Samantha. Appreciate it.
I'll be able to keep linking on.
Thank you, everyone.
Thanks,
Samantha.
Bye.
Thanks, everyone.